Hi, everyone. It's Jason Steele from the Federal Office of Rural Policy. Good to see everyone. I am going to provide a few reminders to you on behalf of Krista. They are stuck in another meeting today and couldn't join us, so they wanted to be sure that you had some reminders about due dates that are coming up around the fiscal year 22 grant. And so first, just a reminder that your annual report is due on August 29th. So that's coming up in less than a month. Whenever we get those, we'll do our best to review those and get that back to you. Your FFR is due on October 30th. And then carryover, if applicable to you, would be due on November 30th. But please, you are always welcome to submit these reports earlier. The earlier you submit them, the faster we can review and get any edits that we need from you. And that is actually all I have today. So I'll hand it back over to Caroline to introduce the speaker.
Thanks, Jason. I think Matt's going to share some SHIP TA team updates. Matt?
That is correct. Thanks, Jason, for just skipping over me. Appreciate that. I know you mean it in love, so that's all good. Hey, hi, everyone. A couple things. Number one, this is my last SHIP webinar to be hosting for you, so I wanted to make sure that we are here, and I am here and a part of this. Always excitement and a blessing to think about the impact you guys have made on me, so that's awesome. I'm staying with the center, so if you need something or want to yell at me, you're more than welcome to do that, even though I may not be working directly with you. So let's see. So one thing that we want to do is remind you that all the slides from the RSV Flex and SHIP session, as well as if you were at the RSV in general, all those slides are now on the center's website in the appropriate places, either the RSV event page or the SHIP tools and resources for the SHIP coordinators. It was a very productive and great opportunity that a lot of people really enjoyed being there. I know several of you were there. Thank you to Dawn and Nick who spoke, helped facilitate that and present on that. So if you're looking to see what was talked about or you want those slides, make sure that you know where they are at. They are available now. If you have not, please take a few minutes to take the RSV post assessment. If you were there and you've received the link, please take a few minutes. If you've not already done that, we're getting a good response. We would always love more. Your voice is very important. Something that's coming up right now is the SHIP TA team is available to review your annual report if needed. You can email SHIP TA or ship-ta@ruralcenter.org. And so that's available. So let us know. We'll review one part. I do believe that's the correct thing. We don't really review for grammar or voice or tense or anything like that. But unless there's something that completely alters the course of your reporting, then we'll mention it. So but keep that in mind. Happy to help you guys with that if need be. And again, we fully anticipate that during reporting periods, you'll have a lot of questions. Please reach out to us with any of those that you have. We will get back to you as soon as we can, and we'll try to get you the right answers. So, and right now, the last thing is that we have best practice nominations that are occurring right now. They have gone out in an email, they've gone out in Rural Route, we're saying it now. And this is for critical access hospitals, small rural hospitals, and rural EMS agency or rural health clinic. So all the acronyms that we use that have implemented an innovative approach around workforce recruitment and retention. Now, we know that's a crazy subject and talk, but if you know someone who's even trying something, or has had good results, we'd love to hear about that. Nominate them for their awesomeness. And that way we can also share that with other people as well. And so those are kind of the announcements that we have. And is there anything else, Caroline, that you think of before I do introduce Clint?
Nope, I'm going to launch the polling while you do that.
Okay, Caroline's going to launch some polling. Please take those real quick. Should just take a few minutes. Not even a few minutes. Should take a few seconds. Sorry, it's not a strenuous activity. And so thank you so much. So at this time, I'm very pleased to introduce Clint McKinney. And Clint has worked in healthcare for more than 30 years. the first 14 years as a family physician in rural Iowa, practicing the full scope of family medicine. He has both owned a private practice and worked with large healthcare system. He currently works as a part-time emergency department physician in rural Minnesota. Dr. McKinney is clinical associate professor in the Department of Health Management and Policy. He's also a member of the Rural Policy Research Institute Health Panel and deputy director of the RUPRI Center for Rural Health Policy Analysis and deputy director of the Rural Telehealth Research Center. Prior to his positions at the University of Iowa, Dr. McKinney worked with nearly 50 rural providers and communities as a healthcare consultant. He served on national committees for the Institute of Medicine, the Department of Health and Human Services, the American Academy of Family Physicians, and the American Medical Association. Of course, in this capacity, that very long bio, which a lot of awesome things. And in this capacity, he does what he's doing right now, which is present this ideas and these thoughts and these experience to interested parties like this. And of course, he does that all over the country. So, Doctor, I will hand it over to you, and
Right.
we're excited to have you here. Thank you.
Well, thank you very much, and thank you, Sally and Tracy, that are there as well too, along with Carolyn. Thank you all very much. And Matt, thanks a lot for the introduction. It kind of reminds me that I actually need to need to update some of that work, because I actually retired from clinical medicine 5 years ago, and I am no longer the deputy director at the RUPRI Research Center, but that's moved on to some younger and brighter folks than me. But one thing that I really have been quite active in over the past decade is rural health value. And that's where I'm kind of coming from today, is that perspective. So I'll talk about that in just a sec. But I wanted to just kind of open with this title slide. And Carolyn and her team kind of asked me to talk about systems versus independent hospitals and kind of the differences and similarities between the two. So I'm hoping I can give you a little bit of a sense of what the differences are, but also what the similarities are between these organizations. First, just a little bit about Rural Health Value. So Rural Health Value is a program project that's been supported for the past decade, now going on in starting our second decade, by FRHP. And it's a combination of both of personnel from the University of Iowa and the College of Public Health, and Stratus Health, which for those of you in the Minnesota area know as the QIO in Minnesota. And we've had a really successful partnership over the past decade, since 2012, kind of promoting this volume to value transitions, both in care and in payment, for rural providers and rural communities. And you can read here what our charges are, but we've developed a variety of tools and resources to help in that transition. We're always interested in healthcare policy and how that either facilitates or makes it more difficult to do the right thing for us in rural. We want to disseminate best practices, just like you were talking about, Matt, that we want to make sure that when somebody's doing something innovative around this volume to value transition, we want to make sure that that gets around the country. We provide direct on-the-ground technical assistance, and then we also share experiences of those, both good and bad, who are making this transition. So that's the background. So that's where I'm coming from. I'm one of the principals in this team, and it's been just a fascinating decade. And it's just, instead of slowing down, it's actually speeding up. So we're seeing more and more of this movement from a volume-based world, which is fee-for-service, to a value-based world. And I'll talk a little bit about that a little later on. But first, let's kind of talk about some hospital fast facts. I'm going to move this just a little bit. So these are a couple of slides from American Hospital Association. And I want to just give you a sense, just graphically, kind of what we're talking about here. So you're seeing that about 2/3 of hospitals, acute care hospitals in the country, of which there are 5,000 plus, about 65% or 2/3 of them are located in urban areas, where about 1/3 of them or so are in rural. And that's despite the fact that the rural population is only about 19%. So what that's suggesting to you, there's more hospitals per capita, but obviously they're smaller hospitals. Now, to get on to what we're talking about today, how many of those hospitals are actually associated with a system as opposed to being independent? And again, now you're going to see a breakdown that's roughly similar as the urban rural cut of 68% are system affiliated as opposed to 32% are independent. Now, what's really important in that is what the heck is a system? So I'm using here the American Hospital Association definition, and you may or may not use it, but for argument's sake, and that's where the data are, we're going to talk about a system as a multi-hospital system is one, two or more hospitals, or a diversified hospital system, which is one hospital and three or more pre or post-acute care healthcare organizations. Think of that as one of our rural hospitals with three or more rural health clinics as an example, or FQHCs, or it doesn't really matter, or a nursing home plus 2 clinics. So that's where when we think about a system, and a lot of, I think, rural hospitals will describe themselves as a local healthcare system because they include home health or an ambulance agency, or, as I said, rural health clinics, for example. So you see again from the AHA data that they're now listing 407 hospital systems in the US. Again, about 2/3 of the hospitals are system affiliated. So again, you're getting some sense of what the numbers look like. So actually the number of system affiliated hospitals is outnumbering independent hospitals about 2 to 1. So I started thinking with that kind of background, I started thinking about now, so what am I going to actually talk about during this presentation? And I started thinking about differences and similarities. It's easy to think about differences, but probably there's more similarities between independent and system affiliated hospitals. But I kind of came up with these 5 categories of differences and similarities. And I'd like to talk about each one of those. So one is ownership. Second is designation. How is the hospital designated? And then number 3, how they're paid. And then where I think the important differences start to come is in number 4 and 5. So what are the operations of these organizations like in compared to one another? And then let's talk about this concept of interdependence, because I think it's a really important one. So let's start first with ownership. Now, here this slide talks about for-profit or not-for-profit hospitals in the country. So this can be systems or it can be independent hospitals. But so this is one of those categorizations where there's actually both independent and system hospitals with different kinds of ownership. But ownership is often divided as for-profit. So for-profit means that you have investors. A good example might be Hospital Corporation of America, HCA, which is listed in one of the stock exchanges. So you have investors that are infusing their investment money into the organization to make it go. Contrast that to not-for-profit organizations where they don't have investors, but instead their infusion of capital generally comes from bonds. So they're borrowing the money. Now there's other forms of investment as well too, like tax support and things like that. But not-for-profits generally, I kind of joke that they're beholden to their bondholders, that's Wall Street, as opposed to the for-profits are beholden to their investors. Now it's not quite as clean as that. And of course, not-for-profits don't pay taxes on their profits, even though they still need to have them. So just because you're a not-for-profit hospital doesn't mean you don't need profit. You still need to be able to be a going concern and be able to be financially successful. It just means that you don't pay taxes on that, and you're more mission-driven than investor-driven. Governments can own hospitals. The most common we may see is a hospital district or a county owning a hospital. And then a type of ownership that you don't really see in the fast facts on US hospitals for the AHA is joint ownership. For example, a county might own the building, but a distant healthcare system may actually own the business of the hospital. Or there may be a mixed management where a system employs the CEO or the leadership team, while the remainder of the employees are actually employees of the hospital that's owned by the county, for example. So there's kind of joint ownership as one other thing you might see. So again, this ownership really doesn't clearly delineate the differences between an independent and a system hospital. You can have different ownerships in both of those types of hospitals. How about designations? So I use the graphic here from CMS because CMS designates facilities as certain types of hospitals. Now, I'm usually referring here to acute care hospitals, so long-term care hospitals wouldn't apply here. Or what AHA often uses is community hospitals, of which there's 5,000 plus in the country. And they can be designated in different ways here. One is a prospective payment system, or you've heard the word PPS hospital. So those are generally larger, generally urban hospitals, but there absolutely are rural located PPS hospitals. I'm on the board of one in rural Wisconsin. It's a PPS hospital, has 36 beds, and it is indeed rural. Then there's critical access hospitals. Now, this is by far what everybody's going to be familiar with, and I suspect that most of you on this webinar actually work at or with a critical access hospital. This is a designation, and there's rules associated with that designation or regulations, but one of the ones that's most obvious is it's 25 or less beds in the hospital. There's no real limit on what services can be provided by a critical access hospital, and there's also no limit on ownership. Systems can own critical access hospitals, and counties can own critical access hospitals, and they can be plain old not-for-profits as well too. There's a new designation, brand new this year, called Rural Emergency Hospital. This is brand new, and gosh, I think it's the first time since 1997 we've had a new hospital designation. And the Rural Emergency Hospital can be independent or system-based. But what's unique about the Rural Emergency Hospital is that it has no inpatient beds, none. So there's no, well, you can have observation beds, people can stay 24, maybe even 48 hours, but there's no inpatient services. They're all outpatient services. And for that trade-off, the quid pro quo is rural emergency hospitals are paid 5% more than other hospital counterparts for their outpatient services. Outpatient services might be lab, X-ray, emergency department, observation care, are all outpatient services. And then there's the special designation hospitals. I listed them here: Sole Community Hospital, Medicare Dependent Hospital, Low Volume Hospital. These are special designations from CMS that allows a little bit of flexibility in payment. And then there's specialty hospitals. Probably one of the most common is psychiatric hospitals. That may be the most common, but you probably may be familiar with orthopedic or cardiology based hospitals. Again, this designation that's primarily done by CMS and states, I would imagine as well too, individually, they really can, it doesn't really matter about independent versus system. Independent or system-based hospitals can be included in all of these different designations. Payment. So how hospitals differ by how they're paid. So I mentioned at the very beginning of the last slide, the prospective payment system hospitals, PPS hospitals. They are generally urban, but absolutely not exclusively urban, using my own hospital where I'm on the board as an example. But generally, they're generally larger, they're generally urban based. And I would suspect, even though we don't have the data right at my fingertips, a little bit more likely to be system-based, but not necessarily. Prospective-based payment uses diagnosis-related groups, or DRGs, or some modification of those, to give a hospital a payment based on a particular diagnosis, usually the discharge diagnosis. So if someone is admitted for pneumonia, community-acquired pneumonia, for example, there is a payment that's associated with that diagnosis, and the hospital receives that payment regardless of how long that patient stays, or regardless of what services, hospital services are provided. That's called prospective payment. Now contrast that to cost-based reimbursement. This is how critical access hospitals are paid. So critical access hospitals are paid by Medicare and some Medicaid agencies as well too, but they're paid based on the cost to provide the care. So for example, if we have that pneumonia patient admitted to a critical access hospital and they're paid cost-based reimbursement by Medicare, whatever it costs that hospital to care for that patient, they're paid. If it costs $3,000, they're paid $3,000. If it costs $4,000 to take care of that patient, they're paid $4,000. But as a reminder here, remember I said that all hospitals really do eventually need to be profitable. You can't operate at a loss forever. So I always ask folks, nominally, how much money does a hospital make on cost-based reimbursement? Answer is zero. It's zero. And it's actually probably in reality less than that. But the point is there's no profit there. So for a critical access hospital to make a profit, its profit needs to come from not cost-based reimbursement, needs to come from Blue Cross Blue Shield or another commercial payer, or it needs to come from tax support, or it needs to come from foundation grants. It needs to come from charity. It needs to come from something different than cost-based reimbursement to support that profitability. There's a few instances where hospitals are just simply paid fee for service. So for example, maybe a hospital has a contract with Blue Cross Blue Shield to get $2,000 for a head MRI, something like that. It's just you do the MRI, you get paid the $2,000 or whatever the fee may be. That's just called direct fee for service. And then the last payment system I want to mention here is something that I'm particularly interested in, and that's called value-based payment. So it's something that could be built on that direct fee for service, but it's still somewhat different. And accountable care organizations, or ACOs, is one example of that. Just in brief, an accountable care organization of which a hospital can participate is paid, or excuse me, let me take this back. Medicare shares any savings that this accountable care organization earns in caring for patients. And this is the way it might work. So if we have a patient that we anticipate through prior costs, they're going to cost $10,000 a year to take care of, and through really good care coordination, we're able to lower the cost for that patient to Medicare to $9,000. So in essence, we just, through our care coordination work, we just saved Medicare $1,000 on this particular patient. If we're part of an accountable care organization, then Medicare shares part of that money with us, shares part of that savings. And let's just say it's about 50%. So we would get a check at the end of the year for this one particular patient of $500, assuming that we've also provided high quality. And if there's quality is a little bit deficient or not where it should be, that may be deducted some. So we always kind of joke that the house always wins. Medicare still made $500 in the best of situations on the work that we're doing. But nonetheless, that's called a shared savings program. And that's where how ACOs work. And it's a value-based payment. CMS also has their value-based purchasing program. This is a quality program in which 2% of funding is withheld for PPS hospitals, and then they have to earn it back through high quality. And then there's also bundled payment programs in which, for example, all of the care associated with a hip or knee replacement is paid in one lump sum. And then the hospital or whatever organization is managing the bundled payment must then manage the orthopedic surgeon fees, the pre-op fees, the post-op fees, the labs, the x-rays, blah, blah, blah. It's all into one bundled payment. And these value-based payments that I've listed here, these and other types of value-based payments are increasingly becoming prevalent. And all of you may have seen that CMS is now suggesting that all of their fee-for-service or traditional Medicare patients should be in some sort of value-based arrangement by 2030. All of them, all of their traditional fee-for-service Medicare. So you'll continue to see this. But back to our independent versus system hospitals, an independent or a system hospital can participate in any of, well, may participate in these. It doesn't really differentiate. Payment doesn't differentiate whether or not you are a system or an independent hospital per se. It doesn't. Now, as opposed to those first three, there is differences in operations between independent and system hospitals. System hospitals, almost by definition, are going to be larger. Now, I say almost by definition because you could have one independent, really large hospital. Gosh, I'm trying to think of a good example where there would be a really large 500-bed hospital that was completely independent. But most of them are going to be associated with systems, but it doesn't have to be that way. But here's some differences, though. Let's just assume for a moment that the system is larger. So a system is able to apply economies of scale to its operations that a smaller, and again, more smaller, and in this case, independent in my example, hospital might not be able to muster. Economies of scale is important in everything from what kind of discounts you get on your pharmaceuticals that you buy or your operating room supplies that you buy, to even being able to absorb financial risk in one of those value-based payments I was talking about. Economies of scale is quite important, and that lends support to the idea of a system-based hospital. Furthermore, system-based hospitals, again, larger, will likely have more support for patient care, information technology, quality improvement. I gave two examples here. I'm just calling that peripheral support, because I think we all know that the central focus of healthcare is the clinician-patient interface. That's kind of it. And then, but there's a whole machinery that goes on around that to support it. And there's likely more opportunities to support that clinical interface in systems than there is in small organizations. Similarly, there will likely be more process standardization in systems than there is in smaller independent hospitals. Now, that may be good or bad. Though process standardization and quality improvement is generally a good thing. But what happens if you standardized a process for paying physicians that compensated them for seeing patients as fast as they can? Well, that's not a good standardization. So process standardization can be good or bad, but there's more likelihood that processes will be standardized both in financial management, in clinical management, in population health management, in relationship management, more standardization in systems than there would be in smaller independent hospitals. One of the things that I hear about frequently, because my experience, not just in 50 rural hospitals and communities, but more like 75 to 100 now, is this issue of depth of the bench. So where do we go when our CFO retires? Who do we tap? How do we tap to fill in from the bench? And systems will have the opportunity to have a deeper bench than smaller independent hospitals. So that can often be an advantage. Decision making, on the other hand, systems are going to be more cumbersome in their decision making. Small independent hospitals with a relatively limited decision making structure or leadership structure can be more nimble. That's the word that's often used. They can make decisions more rapidly. They can respond to challenges more quickly. And so therefore, decision-making in a small independent hospital may be an advantage to being smaller, maybe. Now, we may also say that there will be more experience in decision-making in the larger organizations. But nonetheless, there's differences. There will likely be differences in operations around decision-making between independent and system hospitals. The last one I've mentioned here is cross-learning and coordination. One, I think, of the disadvantages of being independent is you have fewer opportunities to learn from one another. You have a smaller group to be able to learn from, a smaller group to coordinate with. And even though coordination can be more difficult in larger organizations, I think that there's a disadvantage to not having cross-learning. So one of the ways that some work I'm doing is trying to get around that is developing networks of rural hospitals. So even though they may be independent, they're not system owned. But how can we start thinking about ways that rural hospitals who are not owned by systems, they're independent, not-for-profits or county owned, how can they learn from one another and how can they coordinate care together? So just because you're independent doesn't mean that you can't actually start to work with others. And that's where I want to get to this concept. And I'll start to leave you with this concept of interdependence. Boy, I'll tell you, if I had a nickel for every time I've heard we want to be independent, as if it were a mission statement from a hospital, I'd have quite a few dollars. So I wrote here in this bullet that independence is not a mission. Now, instead, if I could reframe that comment to we want to have local decision-making authority because we think we know what's best for our community. And our mission is instead to have quality healthcare that serves our community in perpetuity. That's very different. That's very different. So independence isn't in itself virtuous in healthcare, in my opinion. Decision-making for your community that serves your community in perpetuity is virtuous. So what the goal is how do we start to design models that facilitate working together to support all those advantages that I talked about in operations, such as economies of scale, cross learning, depth of bench. How do we start to engage those types of opportunities while maintaining independence from systems? That's kind of the question. And there's lots of models to be able to do that. It's in this particular slide, which is developed by colleagues of mine at New Point Healthcare Advisors. They talk about co-sponsorship of success, and the word that they really want to use is interdependence. So we start to explore opportunities to develop these relationships, both formalized and not formalized, so we can realize some of the advantages of economies of scale and system without actually giving up the opportunity to have self-determination for our own community. And eventually, what we really want to get to is the triple aim for our local community and for our patients. So I'm going to end with that because I think it's so important. And I think since this was first written about by Don Berwick back in 2008, maybe it's become overused, but I don't think so. It's really appeals to me because I think if you sat down and you had a heart-to-heart conversation with a friend or a family member, and you asked them what they expected of the healthcare system, or no, better yet, what they expected when they saw their doctor, or what they expected when they went to their hospital, I think they would say things like, I want to be made better, or maybe I don't want to get sick at all. I want you to help me prevent from getting sick. You know, and also, by the way, I want the same thing for my family members and my community members where I live. I want the same thing for them. And oh, by the way, I pay a lot of money in taxes, or I pay a lot of money in insurance premiums, and I want you to use my money wisely. I want smarter spending. And what are we talking about? And this is very reasonable, rational kind of expectations for the healthcare system. And it's a triple aim. It's a triple aim. So I think the challenge then becomes, how do we achieve the triple aim? How do we achieve the triple aim while retaining some sort of local decision-making authority, while still realizing the economies of scale and the advantages of systems? So that's where I think we really want to go. And the dichotomy of system versus independence, I think, can gradually fall by the wayside. And we can concentrate instead on what these look like and what are their functions, and how can we ensure that our functions serve the triple aim, if not the quadruple aim. So with that, I'll end, and I'd be happy to answer any questions if I can. So back to you, or Carolyn, or Matt, whomever.
Yeah, I want to open it up. If you have any questions, please put them in the chat. Sorry, you can't see me. Hold on one second. Here we are. Now you can see me and my random calic there. Thank you, Doctor. I appreciate you. What questions
Sure.
do you guys have? We have a question that just came in from Alaska. Do you have any recommendations for board education topics for independent hospitals?
Oh, yes. Everything almost. So I'm on a board of my hospital here locally in Wisconsin. And probably the things I probably start with first, if your board hasn't been particularly educated regarding healthcare, I would first start before healthcare with governance, and having the board understand its role in governance in the organization, and the difference between strategic decision-making and operations. It is the bugaboo about every hospital CEO I know is hospital boards that muddle in operations. So if your board has not had education around decision-making, strategic decision-making, which boards should be doing, but operational decision-making, they should not, I would start there first. The American Hospital Association has great resources on board education, as does the Governance Institute. Oh gosh, I'm sure there's other ones. I'm sure there's other ones that have great resources around this. I'd also recommend, again, it sounds like I'm plugging the American Hospital Association. I don't mean to necessarily, is there the American Hospital Association's Rural Leadership Conference. It will be in Orlando in February 2024. And it is a really good education conference that's really designed for rural boards and rural leaders. So I would probably start there. Another thought that I might have, which is probably good for almost any board, is don't feed the board a whole lot of information that you really don't want them to react to. They have a responsibility to ensure that your organization, if it's not a not-for-profit, is fulfilling its mission. That's its job, to make sure you're fulfilling its mission. If you're a for-profit, its job's a little bit different. But nonetheless, for most of us, it's going to be fulfilling mission. So we want to make sure the board is given the data, information to make wise decisions to ensure that the hospital's mission is being fulfilled.
Thank you. And Tracy did add that we have a series of board leadership video series that she has linked to in the chat, if that's what you're looking for. And we did have another.
I can speak to that real quick. So one is a series that was created that has the first link there where it says Rural HCO Board Director Video Series. There's a variety of different topics in that one, including things on governance. The second one, you can see in the title, it says transition to value. So it's all about what you should know, what a board of director member should know about the transition of value, what their role is in that, because it's not operations, but what is their role in that strategic thinking process, and also being aware of change. And then the third one is really new, and it's about health equity and what a board member should recognize about health equity in the rural environment. So all are great, all multi-part series. They're videos, they're interactive. Some of them even have like worksheets or questions to look at afterwards and have a discussion as a board about. So I really highly encourage you to use those.
Excellent.
Yeah, so we did have another question. It kind of feeds into a question I had too. I mean, you mentioned a lot about interdependence versus independence, but we deal with a lot of culture in these rural communities too, who maybe their hospital was their local one and now it's part of a system. They like that independence, right? They like at least the idea of independence. So this question also kind of feeds into that a little bit. I'm from North Carolina. It says, how do we have any examples for helping these small rural hospitals show their value to the larger systems, right? We don't want to lose that value that we contribute, not just to the system, but to the communities, or that identity that we've wrapped around these hospitals. Do you have any examples of that?
I do. It's not really an example, it's a resource. So Rural Health Value has produced a document on demonstrating value of your organization. And it's often just in the situation that the question arose, and that is, how do you demonstrate value as a small rural healthcare organization to a larger system? So there's a resource to kind of to help with that and help quantify that kind of value. Culture is a little bit different, and I would question this or ask folks to expand on this. Why do we want to be independent? Why is independence so important? And if they can articulate a little bit better than independence, and if they say, well, it's important that we're independent because we don't think that a distant organization understands our needs and issues. That's reasonable. And then I would have said, then in the negotiations, whether they be contractual or otherwise with a larger organization, you need to be upfront about what your needs are in your organization. And if you haven't gone through that process of exploring with your community what's important to your community and not expressing that during negotiations with a system that is in some way becoming affiliated with you, it's kind of the onus is on you to ensure that indeed happens. Now, unfortunately, sometimes these relationships develop when you're especially a critical access hospital with hat in hand, and and now all of a sudden your negotiation power is starting to dwindle. Because now you need a bailout or you're going to be closing the doors, and suddenly your strength of negotiation is long past. So now whomever has the pocketbooks can dictate to you what the terms will be. That's why I think we've encouraged that. I think all organizations should have an affiliation strategy. That does not mean you give away the keys. It does not mean you sell your organization. It means you need to understand what your needs and issues are, what value you bring to a discussion like this with a system, so you can converse, if not negotiate, from a position of strength and position of knowledge. So have folks try to think that through. And again, if the contracts have already been signed, and a system has the option of closing your obstetric unit, for example, the horse is out of the barn. But for those of you who haven't made those decisions or those relationships, contractual relationships yet, please think about that.
That's really great. And speaking to, and feel free to put more questions in there. Appreciate you guys asking the questions. And speaking to SHIP eligible hospitals specifically, they're given a finite amount of money every year that it's meant to meet some requirements. And one thing that we've get a lot of questions about, and I have a lot of questions about from time to time too, is how do we live up to the spirit of a SHIP hospital, and these guidelines and these priorities that come down from the federal level, when the control of the purse is not local. Right, like an example may be that, hey, everyone in the state wants to participate in XYZ, but that system particularly doesn't want the money to go to that. They're using it for HCAHPS. How do we communicate the need for that? How do what people would you suggest reaching out to at a system level to have these discussions with?
First of all, I don't know the SHIP regulations well enough to be able to say if there's any regulatory answer to that question, and people like Sally would know that way better than I would. But when you, at the very end, Matt, you asked kind of who would you ask about this? Usually systems have a vice president for network development or a position somewhat like that. And I think it would seem to me that making a collective case from the state as an organization of SHIP hospitals, making that case collectively to that vice president of network development or whatever the title is, might be more powerful. I'm finding in the work I'm doing right now in North Dakota with 23 independent hospitals, our collective voice is way more than 23 times 1. It is one of those 1 + 1 = 3 kind of situations. So I might wonder if a similar kind of strategy might be helpful. Sally, I probably need a little help from you on answering this kind of question.
No, that's helpful. And I was even thinking of a similar question, Matt, for our audience who are they're administering the Small Rural Hospital Improvement Program. So each hospital under 50 beds, they must be acute care hospitals in rural, can receive, it's approximately $13,000 a year for training, hardware, software, to help hospitals meet value-based payment and care goals. So it could be to prepare you to be in an ACO, to be moving into value-based care. So it can be used for HCAHPS, or more importantly, improvement in training, population health software. The priority in this new year is preparing for ICD-11. That's new change coming for all hospital, and it's both critical access and PPS hospitals, Clint. But and some states are finding that whether they try to create a SHIP network themselves at the state level or pool and invite hospitals for trainings, or equipment, software. Yeah, sometimes there's this, resistance, or just, it's too complicated to have our 12 system-based small rural hospitals participate, or if it's a state doing individual reimbursement, it's almost like that we get feedback sometimes. The system will say, well, we got this, we got quality training, and it's just too bad, because then we know how tight the financials are for small rural hospitals, who the majority are still in cost-based reimbursement. So that's kind of the background on the regs to me, to get the question. But if you have, from your perspective in rural health value and working for independent and system hospitals, if we're just looking for, who's the best person to approach, and are there certain, whether it's training or approaches of peer groups that would be things that systems you think would support for their rural hospital affiliates?
Well, I'm going to just make a guess that many of you think the same thing, that $13,000 really isn't very much, and the program is what the program is, but 13,000 times 20 is a lot, or whatever the hospital number is. So I wonder if demonstrating what can be done with $260,000 as opposed to $13,000 in a state would be persuasive to a network or to a system. I don't know the answer to that. I don't know if it would be, but it just seems to me that individual money is low enough per hospital that you're going to get more bang for the buck if you're able to pool resources for education or for IT platforms or whatever.
Okay, we did have a couple other questions. Thank you. And sorry for just saying SHIP unilaterally and just not providing context. Thank you,
No,
Sally.
that's okay. That's okay.
The next question was, do you have any suggestions or tips on how to develop or create a network of independent hospitals with the intent to negotiate managed care contracts?
Oh boy. I have a lot of experience with that, because that's exactly what we're doing in North Dakota. First, as you can imagine, there's really long answers to this question, but let me just do a couple of highlights. First, like in almost everything else, it's all about relationships. So first is establishing those relationships with independent hospital leadership first, and that means things like going out to dinner together, or if you're a golfer, playing golf together, or whatever. So you make sure that you're seeing some similar interest among your colleagues around the state or region, whatever you're looking for. Next, this is not a new concept. We have, I know there's folks on the call from Texas. We have Torch down in Texas. We have the Rural Wisconsin Health Cooperative in Wisconsin. We have ICANN, the Illinois Critical Access Hospital Network in Illinois, Pat Scow and Tim Size, and it's John Henderson, isn't it, down in Torch? Anyway, yeah. So this is not a new concept. The Rural Wisconsin Health Cooperative has been around since 1975. So there's lots of people in the country who can kind of help with this. Next, no, it takes time. The relationship building has been going on in North Dakota for about 18 months. And so maybe a little longer. So already that's happening. Now, the next thing is, here's really what's really important in that question that you had. In my work in North Dakota, the CEOs immediately jumped to negotiating with managed care companies. Well, independent hospitals negotiating with a third party is illegal. That's price fixing. And the Department of Justice has real clear rules against doing that. So you cannot do that as a loosely affiliated group of hospitals. Instead, what you really need to do is to develop a clinically integrated network. So a clinically integrated network is, in kind of somewhat basic terms, it is physician or clinical governance. So it has to, this isn't just hospital leaders, it has to be clinically governed. The CIN does by clinicians. It needs to have a quality improvement strategy. It needs to have accountabilities built in for those clinicians, and it needs to have assume financial risk. So once you establish that CIN, and they're usually established as an LLC or something like that, so it's usually a separate organization, then you can go to developing, having those conversations with payers, but not till then. And it really becomes somewhat difficult to know what's the chicken and the egg. And I've kind of joked, I really don't want to spend my retirement years in antitrust court. So what we've hired some pretty expensive legal advice up in North Dakota to make sure we're doing this correctly. And it's kind of in parallel. We're developing the CIN, which that's my baby, is to develop the CIN, while other folks are kind of developing the business models. But you'd really need to be very careful about that. Really do. And I think using Torch as an example, forgive me if I get my numbers off a little bit here from whoever's in Texas, but there's a lot of rural hospitals in Torch, like 100 or something, but only about 20 or 25 of them are in their CIN starting. So they're kind of building. So the two can go separately. ICANN, I think Pat Scow has 54 hospitals in ICANN, but something like 18 are actually involved in their ACO or their CIN. So we're in North Dakota, we're going kind of in parallel. So all 23 will be in the CIN, but it's developing right now.
Hey, Clint, this is Sherry from Texas. And
Yeah.
the reason I ask, Torch is set up their CIN. I think we've got like 20 to 25.
Yeah.
But what we're hearing, I mean, kind of on boots on the ground, they're impatient, wanting to get it, get to the negotiation, but it's like, well, and Kwong and John, are working it, that they're doing a great job. I just didn't know, because I know you talked about networking, and I didn't know if you had done any of the other, heard of any other types of networks. But yeah, Texas is good on getting it. It'll be there in a few years, I guess. We'll start negotiating.
Well, it's coming, in North Dakota, I have almost weekly communications with Blue Cross Blue Shield of North Dakota. Why on earth would Blue Cross Blue Shield of North Dakota want to talk to Clint McKinney? Well, they wouldn't, except for I've got 23 hospitals and 250,000 covered lives behind me right now. And when that happens, then people are interested.
Right.
So I think that develops, but you do need, from a legal standpoint, you need to be sure that you don't put the cart before the horse. You need to kind of make sure legally that you're developing that CIN before you talk about negotiations. Although it seems like the CEOs, they want to jump right to that negotiation, and I kind of
do.
The time out, and you know what? I've said this probably a dozen times. I said I'm going to grab people by the shoulders and shake them until they believe me. The purpose of this network is to improve care for rural people. That's its fundamental purpose. It's that. All this other stuff is peripheral. It's peripheral to support that one fundamental goal. And if it doesn't do that, why are we in this business? So the first thing we do is improve the care for our patients and our communities. That's the first thing we do. Everything else follows.
Thank you. And thank you, Sherry, for sharing from your
Thanks, Sherry.
perspective as well. Caroline's going to launch our post-closing as we wrap up the hour. And we did have one last question, and that was, do we have a sense, or do you have a sense of a break-even point for number of covered lives in a rural hospital?
A break-even number for like an accountable care organization?
Yeah, this is Mary. I
Hi,
asked the
Mary.
question, sort of like, you're ahead of most of us with small hospital value-based care. Have you seen any contracts where that size really made a huge difference and it was too small and it bombed really early, or that was?
Yeah, so I think I have some guidelines that may or may not be helpful. So Medicare requires 5,000 lives for the Medicare Shared Savings Program. So that's 5,000 Medicare fee-for-service patients. Most rural hospitals that I know do not have 5,000 fee-for-service Medicare patients in their service area to be able to do that. Now, larger PPS hospitals will, but not very many. Not very many rural hospitals, CAHs, have that number. Because remember, Medicare Advantage patients do not count.
Oh,
It's only fee-for-service traditional or original Medicare that counts in that number. And Medicare requires 5,000 lives if you're going to go alone. Hence, that's why what we call the aggregators are so popular. Signify Health, previously Caravan, soon to be CVS, whether they rebrand it that way or not. That's why they're so popular. They're putting lots of small hospitals, both rural and urban, and clinics, their lives together. So I don't know how many lives they have in Signify. Maybe somebody on the call knows, like 100,000 lives or more. And, and then they're able to mollify the risk that comes with such small numbers. So you'll see a lot of that. You'll see a lot of that happening right now. 5,000 lives, number one, it's tough to get to, just with being a rural hospital and associated clinics. And even if you do, that's a lot of people are saying that's too small, and hence the popularity of the aggregators.
yeah, that was there. I was part of a couple behavioral health Medicaid projects in another state and the rural, that catchment area was problematic.
Yeah,
in
it
rural
is.
areas. Yeah.
It is. And there's that economies of scale coming back to bite us again. And here's where, if we had economies of scale, we would be able to somewhat more easily participate in those programs. Now, the aggregators are making it easier. Medicare's trying. They're trying to set up things for us to be able to participate in, but it's still not perfect. And we are at a disadvantage in the economies of scale.
Well, thank you everyone for being here today. Thank you, Dr. McKinney, for being here and sharing your information. Caroline, there's some extra links in the chat if you want to follow up. If you have any more questions about this topic or any topic, feel free to email us. We'll make sure that gets to the right person to answer. And of course, this recording will be made available in the next week or so, and we will send out a reminder to that. We'll probably make sure we include the links to the board video series, etc., in those, so as a supplementary and a copy of the slides that were shared today. So thank you everyone for being here. Thank you again, Doctor, for being here, and we will see you guys next time. We appreciate you.
Okay. Thank you. Bye-bye.
Bye, everyone.